So please help me welcome Dr. Chris Keary to tell us about behaviors and Dup15q.
Thank you. Thank you. Appreciate it.
All right. Can everyone hear me okay? Great. Keary, thank you for that really wonderful and heartfelt introduction. I'm really honored and pleased to be here. I'm going to turn on my timer because psychiatrists talk too much, and this will keep me on track. Great. All right, let's see how this works here. Fantastic. So I'm a psychiatrist. I work with kids, teens, and adults with Dup15q at the Dup15q Center at Massachusetts General Hospital for Children in Boston. This is where my clinic is, up in Lexington, where I work with a number of kids with Dup15q and adults. I see some friendly faces in the audience. Pleased to talk with you today about what are some of the more common chief concerns that families come with. I'm going to talk about these particular areas of concern, which probably represent around 90% of what some of the chief complaints are. Hopefully this will fit with some concerns if you all have them today. We're going to talk about one representative case for that particular chief concern. We're going to talk about some treatments that I might recommend that are non-medication based, and some treatments that I might recommend that are medication based, a little bit about how they work and risks and benefits, and then we might have some time for questions. I'll try to make sure these slides are available to you all at a later time after the conference. And for people's questions I can't get to, I'll hang out right outside the area there if people want to come up and introduce themselves to me and ask any other questions. I love getting a chance to meet people. All right, let's jump right in. These are my disclosures. I always start every talk with talking about my disclosures. I'm not going to talk about any treatment today or medication that has any connection to sources of funding, research funding or otherwise that I've received. Also, we're going to talk about medications that haven't specifically been studied in Dup15q, though many of them have been studied in kids and adults with autism, but they can still be effective. And so I give that little disclaimer right from the jumper. All right, let's talk about our first case. Sam's a 7-year-old with interstitial duplication 15q, and the main concern here is hyperactivity. Parents are saying that Sam is constantly in movement to the ability that he's capable of because he does have challenges with his motor function, but Sam is busy all the time. He's kind of always been that way, kind of gets into everything. Parents have to watch him closely because he can hurt himself inadvertently, accidentally, and if there's unstructured time, it kind of goes through the roof for Sam, where he gets much more intense with a lot of this impulsivity. And it's become a real challenge for a lot of his therapies, speech therapy, occupational therapy, physical therapy. It slows his progress down because it's hard for him to hold his attention for long enough to make the kind of progress that his family would like to see him making. So it does get in the way of Sam's life in that way. So let's talk a little bit about some treatment ideas. When I think about hyperactivity, I think about trying to enrich kids' day for physical activity as much as possible, to the extent to which meeting them in terms of their particular capabilities, in terms of motor function, and trying to enrich that day for getting that energy out as much as possible. For a lot of kids and adults with Dup15q, hyperactivity can persist into teenage years and adulthood. So for adults who are in a day program, I still want to encourage enriching their daytime activities for physical activity to help with hyperactivity or impulsivity. And regular sleep as much as possible can also make a difference here. Educational interventions involving movement breaks can be very helpful for kids who are distracted by peers, trying to minimize those distractions during the really key therapies, physical therapy, speech therapy, occupational therapy, using reward systems and praise to kind of incentivize staying on task. Maybe someone can focus for only about 2 or 3 minutes. Can we get to 5 minutes if we've got sort of reward system in place or kind of incentives in place for kids who are motivated in that way? And making sure that all staff, teachers who work with that individual with Dup15q knows that the combination of some motor challenges and ataxia and hyperactivity can create a fall risk, and making sure that everyone's got that top of mind. Occupational therapy has a lot to offer for a lot of the concerns I'm talking about today. It can identify calming strategies like weighted vests or hand fidgets. Kids with hyperactivity have a lot of restlessness in the school environment, and OT can oftentimes have a lot to offer for these kids in terms of helping get some of that energy out. When it comes to medications, this is a common place that oftentimes gets started for kids and adults where the severity of hyperactivity is really life-limiting. Guanfacine and clonidine, these are medicines that bind to receptors in the brain called alpha-2 receptors. And in that way, they do the opposite of the fight or flight response. Do people know what that is, the fight or flight response? That sort of surge of anxiety with pacing, heart rate going up, blood pressure going up, kind of fearfulness. They do kind of the opposite of the fight or flight response. They block the effects of adrenaline or norepinephrine and epinephrine. And so in that ways, they're calming after you take them, and they can help with hyperactivity. And they've been studied in kids with autism down to around the ages of 5 or 6 and found to be, show good tolerability and safety. So this is a really common place to start, especially in younger kids. Constipation, tiredness, you can see as potential side effects, important to watch for. And if you make quick dosages too quickly, you can get headaches or irritability. So I kind of watch for those. Stimulants are what most people think of when they think of medications for ADHD, hyperactivity. These are methylphenidate products like Ritalin, Focalin, and mixed amphetamine salts products, Adderall, Vyvanse, Dexedrine. The way these medications work is they stimulate the frontal lobe areas of the brain. It's kind of weird to call them stimulants because they're calming, but they stimulate a part of the brain that's responsible for inhibiting impulses. That's kind of how they work, how they got their name. And those parts of the brain are growing in all kids as they get older and hopefully getting stronger and helping with impulsivity. But it kind of activates those parts of the brain and by increasing dopamine in those areas. These medications are the most effective for hyperactivity. They're the most effective for inattention, but they can carry some risks, appetite decrease, and some kids get more irritable, more emotional, more kind of emotionally raw or anxious. Usually it's not a subtle thing when it started. It's like I get a call like a day or two after being like, Dr. Keary, we got to stop this. So usually when it's present, it's notable. And also it has to be out of kids' systems by the afternoon and evening because it will get in the way of sleep. So to address that issue, there's a class of medications that are once a day. These are norepinephrine reuptake inhibitors. They kind of work in a different sort of way to increase dopamine in the frontal lobe areas of the brain by affecting norepinephrine. And they work all day long. Atomoxetine, which is Strattera, needs to be swallowed. So they came up with a new version which doesn't need to be swallowed called Viloxazine or Kilbry, which has been a helpful addition for kids who don't swallow capsules. I always mention atypical antipsychotics. We'll get more into the risks with that medicine in a moment. But for kids who have both aggression and hyperactivity, this can be a treatment that can help with both. And so I don't prescribe it just for hyperactivity, but for this combination of issues which can come together, it can be a godsend. All right, let's talk about Nora, 23-year-old woman with an isodecentric chromosome 15q. And for Nora, a lot of the issue has to do with rituals, intense focus on rituals, whether it's flushing the toilet over and over again, going and repeating turning the lights on and off. The rituals can really be intense for Nora, and they can get in the way of the areas of her self-care skills that Nora can do. She's so distracted by these rituals that she's not focusing on these things. Similarly, it's getting in the way of sleep. She'd rather do the rituals even than sleep sometimes. So that's how profound they are and needs a strong need for routine. These are things that are common for kids who have an autism behavioral profile as part of their Dup15q. That doesn't always need to be a focus of treatment. I try to look at, is it really getting in the way of their lives before I think about necessarily a treatment program for it per se. But if it's getting in the way like it is for Nora, then it is worth taking on in treatment. I'm a big believer that structure during the day can help reduce impairing repetitive rituals. I was given a crash course in this with the pandemic, where schools closed down, we had a lot more open-ended time, and for a lot of kids with a sort of autism behavioral profile for their Dup15q, rituals got way more intense. I'm a big believer kind of the more you do the rituals, the more you do them, if that makes sense. So kind of filling up the daytime with other structure can help reduce them. Applied behavioral analysis, which I'll mention once more, using reward systems, looking at antecedents for certain behaviors and consequences in order to understand them a little better. Behavioral programs can be designed that can help reduce rituals in some ways as well. Like for instance, for the repetitive flushing behavior that I talked about, using a timer, for instance, where after a certain number of minutes, we're all done and we're moving to the next thing, and then there's a reward if people can make a good transition. That's kind of what a behavioral program might look like for getting stuck on a certain ritual. And then again, OT can have things to offer. When the rituals are very body focused, like repetitive picking at skin or repetitive chewing, OT interventions like chewy tubes or things like that, or hand fidgets, can give that same sort of repetitive ritual need in a way that doesn't hurt the body. All right, let's jump on to talk about Michael. Michael's 27-year-old man with Dup15q, and the major concern parents are coming forward with is aggression. With non-preferred demands for Michael, he's got a quick move to frustration and may move to a hit or self-injury or property damage or elopement. And this has made it really unsafe to put any demands on Michael. This was less of an issue when Michael was 9. Now he's 27. It's a much bigger issue. And it's really life-limiting for Michael. It makes it very hard for the family to go on community outings with Michael. It's very hard to find a day program that would accept him. So Michael's life is a lot more bunkered than it should be. It's harder for him to have new experiences in new places. And there's kind of a persistent irritable mood for Michael, which is kind of a hardship for him and the family. Parents have even wondered whether or not anxiety was a part of this for Michael, because when there's a new experience for him, that can also trigger a lot of these behaviors, and making them wonder whether anxiety is kind of a part of it. So in terms of thinking about non-medication treatment approaches, again, I think about occupational therapy to see if calming interventions, sensory interventions can make a difference. For a lot of kids and adults with Dup15q, frustration comes from not being able to communicate, not being able to state your wants, it's frustrating, I think. All of us could identify with that. So I think about trying to prioritize the long game for helping with this is giving as many communication strategies as possible, and strategies around being able to do things like request a break and understand what that means as a coping way to deal with frustrating feelings. The request a break, that's a very useful communication strategy, or requesting preferred items, or a visual schedule to give individuals with Dup15q a sense of what the plan is going to be. We're going to do this, and then we got the more fun thing on the other side of it. We remember what we're working for with the visual schedule. ABA, Applied Behavioral Analysis, Behavioral Therapy, it's not the right thing for everybody, but it can be helpful for this issue as well, to help identify what are the antecedents that result in aggressive behavior, to understand what drives it, and to use, institute a program of first this, then that, kind of a reward system with non-preferred demands, or to help with transitions from a preferred to a non-preferred activity. Sort of formalizing a program like this, using a visual component to it, can make a big difference. Sometimes instituting a new behavioral plan, you can get a burst, what's called an extinction burst. Things get a little worse before they get better, but ideally that should improve within a period of a couple days, giving you a sense you're on the right track. And I always try to make sure I'm not trying to treat in a psychiatric way a medical issue like constipation. There was a recent study in 2021 that found a strong correlation between constipation and aggressive behaviors. So I really kind of want to make sure I'm not seeing that as the cause for behavior. Is there a clear correlation between the most recent bowel movement and these behaviors that might suggest constipation, dental problems, and is irritability a post-ictal thing? Confusion or sedation after a sort of bunch of seizures that might suggest that that's more of what's going on, and we need to focus on getting the seizures stable first. So those are kind of the most common medical contributors I want to kind of rule out. When it comes to medications, this is a mild place to start. This medicine's called buspirone. It's an anti-anxiety medication. It's probably one of the most best tolerated medications in all of psychiatry. It works similar to antidepressants, Celexa, Prozac, medicines like that, but for whatever reason, its mechanism of action is really well tolerated by kids with developmental disabilities who tend to be more sensitive to medicines. And it's a good place to start when symptoms are less mild. Some kids don't need an everyday medicine. They might just need a medicine prior to like a plane trip or a conference or a family visit altogether, or something that's a particular stressor for that individual. And so benzodiazepine medications like Ativan, Xanax, Valium, some people that can make a big difference. Propranolol is a treatment for panic attacks and can also help in this situation when the medicine is given 1 hour prior to sort of go time. The frustrating situation lasts about 4 to 6 hours and it's out of your system. That can be a better option for many people than everyday medicine. I mentioned in the most severe cases, for like Michael, it's really life-limiting, a lot of these challenging behaviors. And for situations like Michael, mood stabilizer medicines can be a godsend. There are antipsychotic medications that have been studied best. That's a little weird, right? Why should a treatment for schizophrenia be helpful for anger management or irritability or mood? We don't know why that is. but there have been a number of well-designed trials in kids with an autism behavioral profile that have found it can be extremely helpful for challenges with mood regulation. I think about it helping with the quickness of mood change, primarily, these medicines, how quickly you go from 0 to 100, and with unsafe behaviors connected to that. But it's important to watch for appetite increase, weight gain, sedation, constipation, and a rare risk for movement side effects, twitches or muscle spasms. That makes these medications down at the bottom as sort of the last ones I'll consider, or in situations where really it's the most life-limiting. And there are a couple of anti-epileptic medications that also are effective as mood stabilizers. It can be kind of a two birds with one stone kind of situation. Depakote is probably the most effective as a mood stabilizer of all the anti-seizure medicines. Carbamazepine, oxcarbazepine, and topiramate have also been helpful. I have a number of patients with Dup15q that got better with these medicines, which also treated their seizures, and we never needed something more severe like an antipsychotic. So it can be something to discuss with the neurologist if this is a co-occurring issue. Our last case is Iris. Iris is 11 with Dup15q, and Iris's sleep used to be great, and then she had a really rough go of it with her seizures. They were very severe for a couple-month period, and family had to really be in there when she was sleeping to make sure that she was not having status epilepticus, severe seizures, that she didn't need a medicine. And so over a 6-month period, they were kind of in there a lot more with Iris. Seizures got better, but Iris really needed parents to be present all the time in order for her to go to sleep, with big tantrums if they weren't, and a lot of waking up in the middle of the night, where's family? And so now it's taking hours for her to fall asleep, and she's agitated when she's left alone. So when I'm thinking about sleep disorders, which are common in Dup15q, I think about, is there a sleep onset association? What this is to say, does the child or teen or adult really need for the parents to be present in order for them to fall asleep? And if that's the case, it's worth thinking about a behavioral strategy. Whenever I talk about this, a lot of families say, we tried that and it didn't work. So it's not for everybody, but there is some research that shows it really can be helpful, even for kids with bad sleep disorders. And the idea behind these behavioral strategies is to remove that association, needing a parent to be there in order to initiate sleep. Getting kids, teens, and adults comfortable with being in the bed alone, initiating sleep without the parent being there. And the theory behind this is that it also helps with middle of the night waking up, because all of us go into lighter stages of sleep naturally in the middle of the night. And for kids who need parents to be there in order to fall asleep, or adults, when they go into those natural sort of lighter stages of sleep and wake up, now they need the family there, and it's a big thing, and they're awake, and everyone's awake. So addressing sleep onset associations early in the night can help with middle of the night wake-ups as well. And behavioral strategies here include bedtime fading, moving the bedtime counterintuitively back so that kids are really zonked when they're going to sleep, and that helps with the separation. There's a bigger sleep drive at that point when they separate. It can help with separation. The excuse me drill I kind of like. This is like you're starting the nighttime routine and you're in bed and head's on the pillow and say, oh, I forgot this one thing, I'll be right back. And you're gone for 5 seconds and you come back and, oh my gosh, you waited for me. Great job, I'm so proud of you, way to go. And kind of extending the length of the time that you're away, 5 seconds, 10 seconds, 15, 20, kind of to build the child, teen, or adult's ability to be in the bed alone and tolerate that without the family member being there. That combined with a medication, this can really help with sleep onset association. I think about ensuring that the sleep environment is cool, quiet, blackout curtains, dark, consistent sleep schedule, consistent bedtime. And for some individuals, it's really about using things like a sleep-safe bed, a 3/4 door with a camera in there, making sure the sleep environment is safe. It's really about getting people comfortable with being in the bedroom when they do wake up until they settle back to sleep, allowing family to get some sleep themselves. That's a really reasonable goal as well. And then briefly on medications, melatonin comes in short-acting and long-acting versions and can be quite helpful for sleep and is a fair place to start in young kids. Clonidine is helpful for sleep initiation, trazodone for sustained sleep or middle of the night cycle awakening. Mirtazapine has been studied in kids with Angelman syndrome who have some of the most severe sleep issues, and it can really help with sleep, but it can increase appetite, which making it sort of farther down the line. Benadryl and medicines like Ativan and Valium can really help. Some kids can get more hyped up more sort of a paradoxical response and reactions. You got to kind of watch for that. And then the last one I mentioned is that there's an antipsychotic medication called quetiapine. I consider this for just the most severe cases because appetite increase can be a real problem with this medicine, but it can be very helpful for sleep. Whew. Okay, so there's a crash course in my behavioral concerns and what I know about the most recent concerns. Let me open it up for some questions here. At this point, it looks like we maybe have about 5 or 10 minutes for questions. And I'll make the slides available, and then I'll hang out in the back for those of you I can't get questions for if you have them.
Do 5 minutes, and you did get through a lot in a short time. Thank you. My goodness. All right.
Hi, I parent a Michael, and she is taking Geodone, which has been a lifesaver, but she really fights taking medication. So her last hospitalization, the doctor recommended maybe like Halidol, which they can give in shot form. They said then she could just get a shot every couple weeks. What are your thoughts on that?
Let's see. So I mentioned antipsychotic medications, but there's a distinction among antipsychotic medications. They're not all created equal. And there are older antipsychotic medications, which are called typical, and then atypical, which are the newer ones, risperidone and aripiprazole. And the older ones like Haldol, haloperidol, the other name for it, have a higher risk for movement side effects as a potential risk, muscle spasms and muscle twitches. Not everyone gets that side effect, but the risk is definitely higher than in the more atypical medications. It's possible your clinician thought about that because this is a medicine that can come in a shot which lasts for a long period of time, and so it's a logical next step. However, there are atypical antipsychotic medications that also come in a long-acting version, which don't carry as high a risk for movement side effects. It would be a reasonable thing to ask, are there other types of medicines in this class that are injectable that last for a long time that are not Haldol, that carry less of a risk for movement side effects? And to see whether your prescriber thinks those would also be as effective, that's a good way to dodge some of the side effects that can come with Haldol.
Thank you. I think we're going to take one more, and then we have to break to go to our breakout sessions in a second, so one more.
We're on a wait list for a neuropsychologist. We have kind of anxiety, elopement sort of issues. What kind of information should we bring to our appointment for our evaluation? Like, how should we prepare for that neuropsychologist appointment and evaluation?
Yeah, really good question. Neuropsychologists are going to be looking at a wide variety of cognitive domains, but some of the most useful cognitive domains to look at when we're thinking about those behaviors in particular would be looking at attention and focus. Neuropsychologists have got some very formalized ways to assess that, to look at whether that's a co-occurring present issue. So it's worth asking the neuropsychologist whether they're going to assess attention and focus. It might be useful to ask teachers as well if it's a school-age child, or clinicians that might work with an individual during the day if it's an adult, how their attention and focus is in the academic environment, and if they have any particular concerns from a behavioral standpoint that they want to write down for the neuropsychologist. A little like one paragraph summary in terms of what some of their behavioral concerns are. That's going to give the neuropsychologist some flavor of how your loved one functions in the school environment or a day program environment for an adult. That's a good way to be to ask that. There's a wide variety in terms of what neuropsychologists ask for. So asking about how much do you assess sort of mental health piece or make mental health diagnoses would be another reasonable question to ask.
Great questions. Dr. Keary, where will you be afterwards if people have questions?
I'll be right outside the door. I don't want to disturb the next speaker, so I'll be right outside
Actually,
the
you're
door.
fine to stay inside because the next ones are in the next building. That way you're not
Fantastic.
hot.
All right, great.
Yes.
Well, I'll hang out like right here in front then.
Perfect.
Nice to meet you all.
Can we give him a round of applause, please?